First of all, let me make a little disclosure. I'm not a sleep expert. So I am a gastroenterologist, and I've had interest in the area of neurogastroenterology and motility for the last 25 years, with focus on esophageal disorders and specifically on gastroesophageal reflux disease. Part of my work in gastroesophageal reflux disease was involved looking at nighttime sleep time and the relationship between these and gastroesophageal reflux disease. And I had also the honor to work with a big name expert in the area of sleep, Dr. Stuart Kwan, who is now running, I think, the Harvard Sleep Lab. So you all know that, you're all sleep experts, that regular naps prevent old age, especially if you take them while driving. Let me show you. This is a paper that we published last year in Lancet. This was an invited review by the journal to look at the effect of sleep on gastrointestinal functioning in common digestive diseases. And if you want to expand later, my presentation today will be really focused on our work. It will not be kind of an overview of the topic, but if you want to expand, this is one place to go. This year in Nature, we also led another review on gastroesophageal reflux disease, which includes also a component, and I'll show a couple slides related to sleep. And last but not least, the Krieger's Principles and Practice of Sleep Medicine. Is that, I don't know if this is one of the main textbooks in sleep. So we wrote the chapter 160, which I think still has not been published. It's still in work on sleep and gastrointestinal health. Okay, so one of the early works we've done was looking at the relationship between nighttime gastroesophageal reflux disease and a variety of sleep abnormalities. This was a systematic review, and we were able to show in this systematic review that nighttime gastroesophageal reflux disease is associated with nighttime awakening, poor next day functioning, difficulty falling asleep, poor sleep quality, overall decreased quality of life, and the list goes on and on and on. Again, showing the close relationship between nighttime GERD and a variety of sleep abnormalities. We then proceeded in a large study that included 41,000 subjects that were surveyed. These were not specifically patients, they were just subjects. And then we looked at those that were based on the survey. We found out that they have gastroesophageal reflux disease and compared them to those that do not. And we found out that those that do have gastroesophageal reflux disease have a twofold increase in experiencing sleep difficulties, 75% increase in experiencing problems with sleep induction, and then 89% increased risk in experiencing problems in maintaining sleep. Then when we took the GERD patients and we divided them to those with nighttime versus daytime GERD symptoms. Let me just mention that we have a lot of patients that have only daytime symptoms. We have very, very few patients that have only nighttime symptoms, and most of the patients have both. So here in this scenario, we compared those that have both versus those that have only daytime gastroesophageal reflexes. And still, if you had the component of nighttime GERD, you had 53% increased risk of experiencing sleep difficulties, 43% increased risk of having problems with sleep induction, and 56% increased risk of having problems in maintaining sleep. So this is an old study that we were not involved with, but it just shows that when you take patients that have also a component of nighttime gastroesophageal reflux disease, then and you look at their quality of life, they will have a lower quality of life than those that have only daytime gastroesophageal reflux disease, or if you compare them to control. So nighttime GERD, through its effect on sleep, reduces patients' overall quality of life. This is a study that we've done at the same period of time where we looked at the effect of nighttime GERD-related symptoms on work productivity, and we found out that if you have frequent nocturnal symptoms as compared to non-nocturnal symptoms, you were more likely to have problems with work productivity, so reduced work productivity score. So what happened from esophageal physiology during sleep time? So this is the data that have been accumulated over the years in relation to alterations in esophageal function during sleep. So there is a marked decrease in swallowing during sleep period. At the same time, there is a significant decrease in salivary secretions. Both of them are very important defense mechanisms against gastroesophageal reflux, because swallowing is important because it initiates primary peristalsis, and salivary secretion is also important because it helps to neutralize the pH of the distal esophagus in the case of gastroesophageal reflux. We see a decrease in upper esophageal sphincter basal pressure, especially as we move towards deep sleep. And that may have any implications in relation to reflux. I'll show you some of the implications. There is the loss of gravitational effect that we have because of the recumbent position. As you all know, sleep is an altered state of conscious. And so what we notice is people during sleep have lower perception of intraluminal events, specifically here intraesophageal events. And decrease in primary peristalsis, as well as decrease in salivary delivery to the lower esophagus, leads to increase in acid exposure time in the esophagus, thus potentially exposing the patient to more severe gastroesophageal reflux disease, more inflammation, possibly complications of gastroesophageal reflux disease. There's also evidence that during sleep, there is a decrease in gastric emptying, and gastric emptying is very important in relation to gastroesophageal reflux disease. Slow gastric emptying promotes gastroesophageal reflux. Also, from an anatomic point of view, if you sleep in the right decubitus position, you're more likely to reflux. It is one of the positions that people like during sleep, and so it's been associated with more reflux than other sleep positions. This is another work that we've done where we specifically wanted to focus on sleep time. And to see what is the distribution of esophageal acid in the esophagus during the time that patient is asleep. And we looked at the 3 phenotypes of gastroesophageal reflux disease. There are 3 of them. One is non-erosive reflux disease, what it says here, NERD. And they account for about 70% of the patient with gastroesophageal reflux disease. So I'd say 60%. Then we have the erosive esophagitis, and they account for about 30%, and the Barrett's esophagus between 6 to 8% of the patients with gastroesophageal reflux disease. And we found out that all 3 phenotypes have the same distribution, although in the case of Barrett's esophagus, this patient had much higher acid exposure during sleep time, but the distribution was the same. It appears to be high during the first up towards the middle of sleep time, and then it stayed low for the rest of the sleep period. So all of them had the same pattern. Now, what are the implications? And this is really the important part of what was the impetus behind a lot of the work that we've done in relation to nighttime GERD, or specifically GERD during sleep time, is the fact that we do know from many studies that if you have nighttime GERD or GERD during sleep time, you are more likely to experience a more severe form of gastroesophageal reflux disease. So patients with nighttime GERD are more likely to have, for example, complications such as esophageal inflammation in the form of erosive esophagitis, esophageal ulcer, stricturing of the esophagus, Barrett's esophagus, which is a precancerous lesion, and then adenocarcinoma of the esophagus. So if you have nighttime GERD, you're more likely to develop cancer of the esophagus. Also, if you have nighttime GERD, you're more likely to develop extraesophageal manifestation of gastroesophageal reflux disease. You're more likely to develop asthma, chronic cough, hoarseness, aspiration, pneumonia, and others. And obviously, you are more likely to experience sleep deficiency, sleep deprivation here, as mentioned, as well as many other complications. Not all of them are mentioned on this slide. Here's a study showing that in patients with heartburn disease, with heartburn, during sleep, versus those that don't have heartburn during sleep, they're likely to have much more severe erosive esophagitis in their esophagus. This is, as you can see, with the orange bars. So A, B, and C are different grading of erosive esophagitis, where C is the highest and A is the lowest. And you can see that those with heartburn during sleep are more likely to have a more severe form of erosive esophagitis. So one of the interesting things that happened, that was about 10 years ago, there was a movement in GI to separate nighttime GERD from GERD itself and try to call it a separate disease. And the reason for that was the feeling that if we separate it, there is support from physiological, clinical, pathological point of view, but at the same time, it also increased the interest of drug companies to develop treatments specific for this area, where we felt that there was a big unmet need, which is still today. And especially if the FDA will recognize that. So this was one of the papers that came out, and they said that nighttime heartburn and gastroesophageal reflux represent a distinct clinical entity which deserves specific attention in the diagnosis and optimal treatment of GERD. However, the FDA response was, no, it is not. So nighttime GERD remains part of gastroesophageal reflux disease, part of the manifestation. Okay, so we did also some physiological work in that area. One of the things we wanted to see is, so the way we analyze pH data. So when we evaluate patients that are suspected to have gastroesophageal reflux disease, we do what we call pH testing. And this is when we place a pH probe in the esophagus of the patient for a period of 24 hours. Many of us have moved since then to what we call a wireless pH capsule, where we put a small pH capsule in the esophagus. It's wireless, and we have it down there for up to 96 hours, and we measure pH. But the principle is the same. And the way we analyze the results of the pH test, even today, is based on what we call body position. So we divided to the time the patient was in the upright position and the time that the patient was recumbent. Now, not necessarily mean that if you're recumbent that you're asleep, and I think I was inspired at the time by looking at my teenage kids who were spending a long period of times in the recumbent position but awake, usually watching TV and doing other stuff, playing video. So this is how we did. My feeling, our feeling was that the analysis should be based on state of consciousness. So if the patient is awake or asleep, and that would be more physiological in order to assess. So we embarked on this study to see which one should be the better one. And so I want you to follow very carefully our reasoning here, so you will understand what we did. So what we did is we decided that the way we'll come up with the answer is really in a very small period of time, when the person in bed, but they're awake before they fall asleep. And we wanted to see what happened during that period of time when the person is awake, but not asleep. Are the pH parameters are closer to the upright position, or are they closer to the recumbent asleep? Because if they are closer to the upright position, then we were right. It should be divided to awake and asleep. But if it was closer to the recumbent asleep, then the way we do it today by body position, that's the way it should be. And what we were able to show that actually the main reflex parameters that we identified during recumbent awake were closer to upright and not to recumbent asleep, suggesting that probably the way to go in analyzing the test is by state of conscious. So either you're awake or asleep and not by body position. So we showed this study, and I have to say that tradition is tradition, that it really hasn't changed the way we continue to look at and assess the test, even though it's very clear to us that one cannot evaluate patients just because they're recumbent and say that this is a homogeneous period. Then we decided to embark on various additional studies in order to further understand the relationship between GERD and sleep. And one of the ways that we used to do studies was obviously confining the patient to a sleep lab and do a polysomnography. Now, when it comes to GERD, it doesn't really work very well for us because we really would like to have the patient in their normal environment. And we would really like them to engage, with the refrigerator on a normal basis, because this is what drives a lot of time their gastroesophageal reflux disease. And so we've had discussions with Dr. Kwan, our sleep expert, and one of the things that came up to our mind is the use of Actigraph, which I know all of you are familiar with. So I don't need to tell you what it is, but this is an example of the Actigraph we use. We now have a much more advanced version of it. But what we did is we decided if we can develop a software, a computer software that can superimpose the information that we get from the Actigraph on our pH data that we collect from patients, then we can know better what happened to patients during sleep time, because we were really interested in sleep time. So the way we know today if patients are asleep when we send them out with any of our functional tests is by patient diary, patient reports. We found out later that it's really non-reliable. In fact, we have data to show that patients were wrong, and many times they were wrong by up to 2 hours. Well, we also found out that many patients fill this diary not the night before or immediately after they wake up, but a few minutes before they hop on the car and they drive to the hospital to give the equipment back. So this is Actigraph recording, and you can see the area where the patient was asleep. Again, the Actigraph is based on hand movement. And we used it in order to tell us if the patient is asleep and awake. So let me show you how it worked for us. So here is a pH strip. Let me orient you on this one. On the left side, you can see the pH. In this situation, you have two sensors on the pH probe. You have one, which is the distal pH. It's about 5 centimeters above the proximal margin of the lower esophageal sphincter of the esophagus. And then you have the proximal pH, which is about 10 centimeters above the previous one, above the distal one. Each one of them contain pH information. Whenever the pH drops below 4, we have a reflux event, okay? The information we get, you can see on the left side, it says supine, probably the proper word is recumbent. So the green area is whenever the patient is in the recumbent position. Now, we don't know if the patient is asleep or not. All we know is that the patient is recumbent. Yellow is when the patient is eating a meal, and then symptoms are marked. You see like a little mark there in purple. So this is the information we got from this strip. When we incorporated the information that we got from the ectograph, then the story of what happened during the recumbent period became much clearer to us. And we start to learn a little bit more about the relationship between sleep and gastroesophageal reflux. So let me just remind you, this is the recumbent period. During the recumbent period, we see 3 episodes of reflux. As I mentioned, when it drops below 4, it's reflux. So during the recumbent period, the patient experienced 3 episodes. There were more than, you see at the beginning that there were a bunch of reflux events. Then in the middle, there was a couple of them, and then another one towards the end. And then there was also 1 episode of chest pain that the patient reported. Now, obviously, in order for the patient to experience chest pain, they have to be wake up. So, but you don't really get that information from a regular pH test. So after we incorporated the actigraph information, then you can see, let me walk you through of what we see here. You can see on the left side that now we have a little bit more information than what the original test gave us. So first of all, the blue is whenever the patient was recumbent and asleep, okay? The green is when the patient was recumbent. So if there is no blue, the patient was recumbent and awake. And you can see it at the beginning of the first sleep period. Now, what you see is that during the time that the patient was in the recumbent position and the patient was asleep, the patient was awoke. The patient had 2 periods of what we call conscious awakenings. One of them was 20 minutes and 42 seconds, the other one of 25 minutes and 1 second. And these are the periods that correspond with the reflux events that the patient had, okay? Also, the first one of them was the one that was associated with the chest pain that the patient reported. So the first round of conscious awakening that was associated with reflux was the one that generated the chest pain. The second one did not generate any symptom, at least that the patient reported. So we got a very interesting information here also that at what we call at the period where the patient was recumbent and awake at the beginning, there was a lot of reflux events going on. So while before the patient fell asleep, the patient was in bed, there were a lot of reflux events, and the patient fell asleep, no reflux events, woke up, reflux events, and you can see the rest of the story. So it gives us, I mean, if we go back, we cannot see that information from here, but here we clearly see the sleep fragmentation that the patient experienced as it was associated with gastroesophageal reflux. So the plot about the relationship between sleep and GERD start to thicken here for us, and we start to embark on additional studies to further look into this. Here are the three sleep periods that I mentioned and the reflux at the beginning before the patient fell asleep. Okay, so before we also embarked on some of the studies, what did we know about the difference between gastroesophageal reflux events and sleep as compared to when the patient is awake? So this is a pH strip, and you can see it one on the right side. There's a line, it says S at the beginning, and this is the sleep period. And so whatever is on the left side is awake period. M and P means meal, and P postprandial. And there were three important characteristics for reflux during sleep as compared to reflux during when the patient was awake. One, there were less of them. So very clearly that most of the reflux events that patients get, they get them while they're awake, not so much while they were asleep. And this makes sense because the major trigger of reflux is food, and eat them while we are awake most of the time. The second one, that they during the sleep period, they tend to be of a longer duration as compared to during wake time. You can see how they separate the reflux events, suggesting that it takes a long time to clear them when you're asleep, but today they tend to be very short on the left side when you're awake. And you see the letters H, that means that the patient experienced heartburn during that period of time. And so the other thing is that symptoms tend to be more common during the awake period rather than during the sleep period. So we did a study, and we looked at the duration of using this new approach with the actigraph and the pH, because we felt that it's a new opportunity to learn a little bit more about this relationship. And so the first thing, we wanted to look at the duration of reflux event. So before we went into the study, we knew that the reflux events tend to be longer during sleep time and shorter during wake time. And the experts explained to us that the reason for that, while you're awake, you can initiate your defense mechanism, swallow, saliva, and when you're asleep, you're less likely to initiate it, and that's why there's a difference. So we looked at the upright, recumbent awake, and recumbent asleep duration of reflux and found no difference. So we couldn't support that finding based on our new technique. But when we looked very closer into this, we found out the reason for that. And that's the reason for that. Here is an example of a patient with a pH test. And you can see that during sleep time, the patient may experience not only longer duration of reflux events, but also very short duration reflux events. At the end of the day, when you look at the mean, if you take the mean, it will be somewhere the same, like what you see in the upright or in the recumbent awake, because it depends if the patient was asleep during the period of the reflux events or they woke up. Now, because at the time they did not have the capacity to know if the patient woke up during the sleep time, they couldn't figure this out. But you can see it here. The patient had 2 reflux episodes while the patient was asleep. One of them looks very clearly as very long, and the other one very short. But at the same time, the short one occurred when the patient was awake. You can see the white gap. So if you go closely, you can see that the longer, it was during the blue period where the patient was asleep. So it took a longer period of time to neutralize that reflux event. And it was very short when the patient was awake. So there's a lot of it going on during sleep that we were not aware of, that there is the issue of patients waking up, and that results when they wake up. Obviously, they're able to clear the reflux much more faster than if they sleep through a reflux period. So the story of GERD and sleep is much more complex than this original work that was done and showed us and gave us a very simplistic explanation. And as we start to deep into this, to delve into this, we found out it's way much more complex. The other thing is we were really interested and intrigued by the period that before the patient fell asleep. So when the patient in bed, before they turn off the light, or I don't know if they, I don't know, before they turn off the iPad. So they are in bed, looking at the iPad, and then after they turn off the iPad, go to sleep. As I mentioned, we noticed that there's a lot of reflux going on in this period, which we call recumbent awake. So we wanted to compare more closely. We wanted to look more closely and compare the recumbent awake period to the recumbent asleep. And so what we did is we took patients' recumbent awake period and we compared it to the immediate recumbent asleep period. So if the patient, for example, had a 45 minutes recumbent awake period, you will be surprised, but some people spend, maybe they look at the whole Netflix episode in bed before they fall asleep. But depends what it is, 45 minutes, I'd say on an average. But so we looked at the first 45 minutes of recumbent asleep. And clearly, when you are in the recumbent, if you look, you will have more reflux events in the recumbent awake than immediately after during the recumbent asleep period. The mean number of acid reflux events is much higher. The mean duration of acid reflux event is much shorter, as one would expect, and the percent with associated symptoms was much higher. So we concluded that this period of time is a vulnerable period for reflux. So one of the recommendations that I have today for patients based on this work is when you go to bed, turn off the light and go to sleep. Don't spend time and take all the videos, the iPads and the TV from your bedroom. So then we delved even a little bit more into the relationship between the two. And this is, by the way, this is, by the way, an example of one of the cases that we reviewed. You see here again, the green period is when the patient is in the recumbent position. And this is after we superimpose the actigraphy data. And you can see that the blue is when the patient was asleep. The green is when the patient was in the recumbent position but awake, and you can see how much reflux there was going on at the beginning of sleep, at the beginning before sleep time. Then the patient fell asleep, then the patient awoke, had a conscious awakening, and then the patient fell asleep and there was less reflux. So that really, it's an example that really told us the story. But you will see that that story keeps going on whenever I show you other examples, even though I talk about something else. So that period of time, each time comes back as a very important period where the patient is in the supine position, and probably being in the supine and awake is a vulnerable position for reflux. So then we explored what is the relationship between conscious awakening and acid reflux events and symptoms. And for us, the definition of conscious awakening was that if the patient awoke for more than 2 minutes. So the patient could experience symptoms. So in order to report symptoms, you have to be awake, consciously awake. So what we did is we looked at patients that underwent pH test, and we found out that these patients totally experienced 104 conscious awakenings during their sleep time. But only 52% of them were associated with reflux events. When we looked at those that were associated with reflux events, we found out that only 31.5% of them were associated with symptoms. So, and if we look at the overall, only 16.3% of the conscious awakenings were associated with symptoms, suggesting that what is common in patients with sleep time GERD or sleep time gastroesophageal reflux is not really reporting heartburn that awoke them from sleep, but rather just waking up. So waking up was more common, just waking up, than waking up with symptoms. So this is something we obviously started to pay attention to it from a clinical point of view, that waking up could be a manifestation of gastroesophageal reflux disease. Here's an example. This is a patient that came to us and complained about severe heartburn during sleep time. You can see the red area that suggests that the patient has a lot of heartburn going on. And you can see the reason for that. When we use the actigraphy, you can see that the patient had 6 periods of conscious awakening that range from 4 minutes to 38 minutes. All of them were associated with gastroesophageal reflux. And then eventually the patient fell asleep and finished the night with actually a good sleep without, not a good sleep, but was able to sleep for the rest of the night without having gastroesophageal reflux or symptoms. What also we found from this study, and that's very important to mention, I'd like to emphasize that now have been consistently reported by other groups, is the fact that most of the reflux events that we have identified in this patient occurred after the patient woke up, not before. Okay, so 88.2% of the reflux events occurred after the patient woke up, and only 11.8% happened before the patient woke up. And obviously, there was a difference in the duration of the reflux events if it occurred before the patient woke up or after the patient woke up. We also decided to look at reflux that occurred in the morning, which is a common complaint that we get in our practice. Patients tell us that they wake up in the morning feeling fluid in their throat, regurgitation, heartburn. This is the title of the paper, Riser's Reflux and Eye-Opening Experience, which I adopted as the title of this lecture. And so we looked and we found out that an hour before patients woke up, only 17.9% of them, we were able to identify reflux. 10 minutes after they woke up, 33% of them had reflux, and 20 minutes after they woke up, it went to 50% of them. And this is before they had breakfast, just by waking up. So the transition so the transition from sleep to wake up in the morning was kind of a big bang for a lot of these guys. They started to get a lot of reflux going on. So entering sleep, exiting sleep, all associated with a lot of reflux. And here is an example. If you look at the bottom, you see the red is where the patient experienced heartburn. This is immediately after sleep period and with a lot of reflux events. We also decided to look at napping because we figured out that maybe napping is something we commonly take after a meal, the siesta, the famous siesta in certain cultures. It is commonly done after lunch. And we wanted to see if it's a good idea to take a nap after lunch. We found out it's a bad idea. That in fact, that when we look at naps, the patients, and we compare them to reflux during sleep time versus nap time, and we found out that during nap time, there is even much higher reflux, much more reflux than we expect to see after nap. Now, let me preface this by telling you that we took the same period of time that patient took a nap after they had a meal, and we also did the same thing with the patient during sleep period. So took the same period of time. And we found out that nap was associated with much higher reflux than the sleep period. Is again, clearly, and this study was published a few years ago, 5 years ago. Okay, how much more time do I have? I'll try to. You're muted. I can't hear you.
About 10, 15 minutes.
Okay, excellent. I need to leave time for questions or
Yep.
if you said, yeah.
A little bit.
Okay.
Yep.
Okay, so good. I still have more info to share with you. There are several studies, epidemiological studies, told us that harbor an awakened patient for sleep is very common. And in fact, there are 3 different epidemiological studies that you can see on this slide, very large studies. All of them suggest that about half of the GERD patients report that. So that's a very common phenomenon. It's not unusual. And patients that reported nighttime heartburn, 63% of them said it affected their ability to sleep well. 42% said that they were unable to sleep through a full night. 39% said that they had to take naps during the day, and 34% said that because of that, they sleep in a seated position. And interestingly, 27% said that because of their nighttime GERD or the heartburn that awakened them from sleep during the night, it affects their bed partner, affect their sleep experience, that it wakes them up also from sleep. So their nighttime GERD affects also their bed partner's quality of life. So this is a study that we've done. This was an NIH-funded study that was published in Chest a few years ago, where we looked at factors. That affects patients. Factors that affect patients' heartburn that awakens a patient from sleep. And we found out that college education is protective. Always when we do studies in GERD, we find out that college education is protective. And then snoring and being sleepy increases your risk of having a nighttime GERD. High BMI, insomnia, benzodiazepines, carbonated soft drinks, hypertension, and asthma. Now, this study ended up in Good Morning America, New York Times, anywhere else. And you look at the table and you wonder why. And I'll tell you that you won't believe it. But the reason why it ended up in New York Times and Good Morning America is because of the carbonated soft drinks, not because of the other important messages that came out from this study that drinking carbonated beverages was associated with heartburn in a woke patient from sleep. We also did some studies in the sleep lab, just to make sure that you know. We did polysomnographic studies. This is, for example, a study. What we did is we were able to incorporate the pH data as you look at the bottom of this polysomnographic strip. And so we can accurately correlate pH events and symptom events with autonomic and then EEG information. Here's an example of a spontaneous arousal that was associated with reflux event. And so this is a study we published in the Journal of Clinical Sleep Medicine. And this study concluded that 90% of acid reflux events were associated with short awakening from sleep. This is something that we did not evaluate with the actigraph. We evaluated only conscious awakenings. Most patients awoke for an epoch of 30 seconds after an acid reflux event, and there were significantly more spontaneous arousal during pH drops and during comparison periods. And that tells us that these short arousals that, as you know, are amnestic, are commonly associated with reflux events, but can also contribute to sleep fragmentation. They occur primarily at stage 2 in this study. So we came up with this model of the relationship between sleep and acid reflux. And we already proved in this model that GERD, increase in GERD, decrease sleep experience. And so the question that we asked, can sleep deprivation per se can affect gastroesophageal reflux disease? So we embarked on a couple of studies related to that. This is the first one that was published in the Journal of Gastro. So what we did is we took patients and normal controls. They were randomized to either good sleep or bad sleep. Good sleep that they had to have at least 7 hours of sleep 2 days in a row, and then they showed up in our motility lab. Bed sleep, they had to sleep at least 4 hours. They slept only 4 hours. We assessed it with the actigraph to make sure they did. 2 days in a row, and then they showed up. So all subjects went through both periods, but through randomization. And what we found out is that when you look at patients, the magenta bars, that and what we did, sorry, I forgot to tell you that when they came to the lab the next day, we introduced a probe into their esophagus and infused acid, 0.1 normal hydrochloric acid at 10 cc per minute, looking to see if we can generate symptoms in these patients. And we found out that after bed sleep, patient appeared to be much more sensitive to acid. We have a validated, calculated acid perfusion sensitivity score. So it was significantly higher after bed sleep and lower after good sleep. Same effect could be seen in control of those smaller. And so it told us that poor sleep or bad sleep, what we called it here, was associated with increased sensitivity of esophageal stimuli. And so we clearly were able to show that poor sleep is hyperalgesic and good sleep is analgesic. Then we did another study. We took it even one step further, and this study was published a couple of years ago. We used the same design of bad sleep and good sleep, but this time we wanted to see if good sleep and bad sleep by itself can affect reflux. And we looked only in healthy controls. We wanted to see if bad sleep can convert these healthy controls to GERD patients by generating abnormal esophageal acid exposure. And we were able to show that after bad sleep, their mean percent total time significantly increased. And 45% of them after bad sleep develop abnormal pH parameters. This is normal healthy controls. So based on this, we were able to show, when we looked at our model, the bidirectional relationship between sleep and GERD, where GERD affects sleep, and sleep by itself per se can affect GERD, and there is a vicious cycle between the two, and the question how you break this cycle. So obviously one way, like in this study that we performed, where we used one of the PPIs, we interfered with the proton pump inhibitors, and we wanted to see the effect of the proton pump inhibitors, not specifically only on GERD, but also on sleep parameters. And we were able to show that giving patients PPI significantly improved their nighttime experience by reducing a variety of sleep abnormalities as compared to those who received placebo. We can see that also by also through improvement in their heart, that we also demonstrate improvement in their heartburn. But the focus really was to see if we can improve with an anti-reflux medication patients' sleep reports, and we were able to do that. So clearly you can break the cycle through the GERD part. Then we asked the question, and I'm sure you asked, can we break this by giving a patient a sleeping pill? Can we, by improving sleep per se, we can improve GERD-related symptoms? So we did that study too. I don't know, you may argue about the medication we used, but we used it, there was a reason why we used it. And we used Roseram, an MT1, MT2 agonist, and then patients with non-erosive reflux disease were randomized to Roseram only or placebo, no other anti-reflux medications for a period of 4 weeks. None of them had inflammation. And we were able to show that just by using Roseram, we were able to improve daytime and nighttime heartburn in these patients. And it was primarily through the effect on the insomnia severity index, using the insomnia questionnaire. So from our point of view, we think that there are two ways one can break this cycle. And the next question, obviously, do we need a combination of both? That study, I can tell you, we haven't done. So just to finish here, this is in one of the recent papers that we published in Journal of Clinical Gastroenterology. Just to let you know, these are the therapeutic options that we offer for patients with nighttime GERD. Very important for us, lifestyle modification, elevating the head of the bed, sleeping in the left lateral position, avoidance of late night meals, and then medications, including hypnotics. As we mentioned, there is data about all of them in relation to their effect on GERD, anti-reflux surgery, and alternative and complementary medicine. Now, I'd like to also say that in our Nature, recent Nature review paper, we like specifically elaborated on nighttime precautions for GERD. And a lot of it included some of the work that we've done, like avoid eating at least 3 hours before bedtime, turn off the light when entering bed, minimize the wake period before falling asleep, and minimize disturbances during sleep time. All the things that you guys recommend anyway, but many patients do not follow. So these are my conclusions. They're very, I just put some essential conclusions, not really following every details that I presented. And remember, I presented primarily a lot of the work that we've done. I did not have the time to present all the work that we've done. We went into other different directions. If you want, I have another 5 hours of presentation, but I decided to spare you. And as I say, never give up on your dreams. Keep sleeping. Thank you.
Good. That was excellent. Brought us up to date, and I think it had a couple questions. One was, is it appropriate for a sleep doctor to start proton pump inhibitors in people that present with sleep disorders? And at least the chat was saying absolutely. Before they get referred.
Yeah, I mean, I think in patient, if you have a patient with gastroesophageal reflux and they have sleep disorders, I would consider a GERD as an important. And I would say that by doing that, you're already ahead of the game of many gastroenterologists, because they don't consider that when they see those patients. That's not on their list. Many times they don't even ask about that. So you guys are more sensitive to it, and obviously, yes. If the patient has primarily nighttime symptoms and sleep disturbances, then I would even position the PPI before dinner and would not give it in the morning. So just tell the patient to take it half an hour before dinner.
Don't see any other in the chat. I have a question about management of sleep disorders, especially OSA, and whether or not you should screen for Barrett's, or you should screen for things, and if there are any indications, or at least some sort of thoughts about what would be thresholds for both symptoms, AHI severity, and then ages.
So these are two different questions, and I did not touch on OSA specifically. It's a different line of work that we've done, because we were very interested to see the relationship between GERD and OSA. So the studies do show that patients with OSA reported a lot of GERD symptoms, and that patients, and then if you treat patients with OSA with CPAP, their GERD symptoms improve. And there's some studies even showing that if you treat them with PPI, their OSA may improve. But we were not sure what is the relationship between the two. And we embarked on a study where we looked at, our hypothesis was that if GERD is really a cause of OSA, then the more severe the GERD, the more severe should be the OSA. And we work with the apnea-hypopnea index, looking at AHI. And we found out that there was no relationship. So somebody could have a very severe GERD, but very low or normal AHI, and somebody may have mild GERD and very high AHI. So we concluded that probably the relationship is not direct relationship, but through BMI. So the fact that OSA and GERD share the same risk factor, which is high BMI. Now, going back to your question, in relation to patients ruling out Barrett's esophagus, so the main concepts are that if patients have, they're over 50 and they have risk factors for having Barrett's, for example, like high BMI, being Caucasian, having nighttime symptoms as well as others. If patients have it, usually they need to be screened at least once during their lifetime to make sure that they don't have Barrett's esophagus, not necessarily if they have OSA or not, any patient.
Terrific. Well, our time there, it's 9 o'clock on the button, and we go on to a session with the fellows in which we'll be discussing a case that we started last week, Dr. Fass. And so thank you very much for your presentation, and thank you for being around. This is a really a kind of a nice way of getting into it. We're trying to look at what sleep medicine can contribute to other specialties as much as what other specialties can contribute to sleep medicine. So this was a good introduction to that. And the bidirectional relationships are being seen with heart disease, with liver disease, with other sorts of inflammatory bowel disease. Those are the other things that sleep and sleep health seem to do. So
I'm going to chime in quickly.
My polemic, yeah.
So I'm Denise DeWald. I'm one of the fellows, and I'm researching the interaction between swallowing and sleep apnea. So actually, people with sleep apnea have an aberrant swallow. So they're not swallowing this with like a normal swallowing pattern. And I can send you the references, but I'm wondering whether that may be involved in this whole like more GERD during a wake, that their swallow is somehow different than people who don't have GERD.
Yeah, I mean, so we discussed what happened during sleep. You're saying that while they're awake, they have
while they're awake.
Yeah. So I'm not aware of that, but it would be very interesting to look in this information. Does it affect reflux? I have to see what the abnormal swallowing is.
Yeah. So
it affects. I mean, from our point of view, what we need from swallowing is to generate primary peristalsis and to deliver saliva to the lower esophagus in order to combat gastroesophageal reflux. If that is maintained, that shouldn't be a problem. But if it's not maintained, it could explain.